webinar. Thank you for participating in our educational initiatives. I want to remind you a few things before we begin. Today's session will be recorded for on-demand viewing later. Your lines are muted, so we will not be able to hear you. However, if you have questions, you should see a question box on your control panel. Feel free to type in any questions at any time during the webinar that you have them, and we will get to those at the end of the broadcast if there's time. If not, the speakers have agreed to take questions and answer them at the conclusion of the event. Today, you will be receiving CNE credit if you're an STN member. About an hour after the broadcast, you'll be receiving an email with a prompt for you to take the evaluation. Once you complete the evaluation, please include your name the way you would like it to read on your certificate, and we'll send those certificates to you within 5 to 10 business days. It's my pleasure today to introduce you to our two speakers. Terri Elsbernd is currently the Pediatric Trauma Coordinator at the Mayo Clinic in Rochester, an ACS-verified Level 1 Pediatric Trauma Center. She joined Mayo in 1990 and has an academic rank of Assistant Professor of Nursing. Terri received her BSN from Gustavus Adolphus College and an MSN with a clinical nurse specialist focus from Winona State University. Terri's other professional activities include serving as a board member for the Pediatric Trauma Society and a member of Emergency Medical Services for Children Advisory Board and the Society of Trauma Nurses. In addition, she is the pediatric representative to the Executive Board of the Southern Minnesota Regional Trauma Advisory Committee. She is an instructor for TNCC, ATCN, and TOPIC. In addition, Terri is a site reviewer for the State of Minnesota Trauma System. Our second speaker today is Diana Fendya. Diana has been the Trauma Acute Care Specialist for the EMS for Children National Resource Center for 15 years. Previously, she was the Director and Pediatric Trauma Nurse Specialist at a Level 1 Pediatric Trauma Center. As part of the NRC, she works closely with the federal EMSC program. She serves as a resource for hospital pediatric emergency and trauma initiatives and provides emergency trauma consultative services to states and territories. Additionally, she has published in numerous peer-reviewed medical and nursing publications, including STN's Journal of Trauma Nurses. If our speakers today have any financial disclosures or conflicts of interest, they will do so before they present. To that, I will turn the floor over to them.
All right. Thank you, Kim, very much. This is Terri, and we're going to start. We just have to acknowledge that Diana is funded in her role by the federal government, so we need to disclose that at the beginning of the presentation. And again, Kim talked about the CEs and so on. So we'll get to the objectives, and again, what we're going to talk about today is trying to help the providers really see if we can provide them some tools to help them deal with the challenges that are faced when taking care of injured children or any child really in a rural, non-populated environment. So we're going to identify those challenges and then again hopefully provide you some strategies that you can use to overcome those challenges. So as we start, again, you know, there's lots of different definitions of rural. Actually, when I looked on some of the federal government websites, I know it's hard to believe that the federal government has multiple definitions of rural depending upon which federal agency you look at. The Census Bureau has a different one. The Office of Management and Budget has a different one. But for our purposes here, again, rural is often defined by exclusion. So anything that is not considered urban or a high population density is considered rural. Even more rural, there is a category called frontier, where again they not only have low population size, low density, but also a very high degree of geographic remoteness. So it's really those last two that we're going to kind of focus on today as where the most challenges do appear. So this is my work environment, and again, when you look at that, you might think, well, you know, that looks pretty urban to me. But how we define rural here in our trauma center in Rochester, Minnesota, is by the fact that if I stand on the top of that helipad that you see on the top of the hospital and drive 20 minutes in any direction, I'm in the middle of a cornfield. So again, we certainly do have some of the urban traits, but we really do consider ourselves a rural trauma center, and again are dealing with some of those same challenges that some of you very well might. And again, the picture on the lower right-hand corner really depicts much more what we're involved with. Again, wide open spanses and long transport times to get our patients to definitive care. So again, in the state of Minnesota, you can see that, again, depending on where you're at, the metropolitan area is very population dense. And again, the rest of us in the non-metropolitan area, they call us the outstate area. Again, our population is certainly not as dense. But interestingly, our death rate per 100,000 is higher than in the metropolitan area, again, pointing to some of the challenges that we're going to talk about and the reason why it's important that we look at them and try to find ways to overcome them. So another way to look at rural trauma, again, as decided by the Rural Trauma Team Development course, is it's unfortunate that 60% of trauma-related deaths occur in these rural, remote areas, despite the fact that only 40% of the nation's population lives there. So again, I think, it speaks to the challenges that those of us that work in these environments really do face. So again, you can't really talk about rural trauma, I don't think. People especially live in the metropolitan area associate rural with farm. So I have to just interject a little bit about farm injuries. We had a research study that was done here at our Level 1 Pediatric Trauma Center looking just at that thing, farm injuries versus non-farm injuries. Turned out they looked at a period of 10 years. It was obviously a retrospective study. And what they found was that only 2% of our trauma team activations were related to farming injuries. But what they did find that the injury severity score was much higher in those farming-related injuries. And again, that the age group most at risk was that 6 to 14-year-old age group, again, when they're getting, starting to be tasked with chores around the farm. And again, a lot of those injuries were caused by farm machinery. Again, there's lots of big, powerful machinery that those kids may or may not be capable of really working with at those early ages. So one of the things that we've done here recently, again, related specifically to farm injuries, was looking at, how can we use some injury prevention strategies to deal with what we found in this study. So there is a farm event in the southern half of our state that's called Farm Fest, and they have 45,000 farmers that come there over a 3-day period. And we decided to introduce this topic about trying to keep children safe on the farm. And I found this poster that we were allowed to use from the Agricultural Safety Group, and really focusing on the fact that maybe we know that all farm families do it, but maybe it's not the place for that child to be on those tractors and on those big machines. So again, our theme was it's easier to bury a tradition than a child. And again, some of these things are so ingrained in these families. I would like to say it was overwhelmingly enthusiastically embraced. But again, we did have one mother that said, how come no one's ever told me this before? So again, we felt very positive that even if we reached 1 or 2 people, again, beginning to get that message out there was a very key message to get out there. So we felt pretty good about that. So another way to think about and defining rural is thinking about how the American College of Surgeons defines rural trauma. So again, they say that a trauma system is deemed rural when the care of those injured patients is delayed or limited by such things as geography, weather, distance, or lack of resources and or lack of experience. So again, there's lots of different ways to look at it, but when you're thinking about taking care of trauma patients, these definitions from the ACS really do provide us some of our biggest challenges. And again, we'll talk more about that as we move on later in the presentation. So we have a participant question for the group. So again, we're interested in what best describes your work environment of the 3 choices we have here.
So to participate in the poll, you just need to select one of the options. It looks like we already have about 40% that have voted. We'll give you just a few more seconds to get your vote in. Okay, I think we have about 80% that have voted, so I'm going to go ahead and close the poll and launch those results. Okay, Terri, can you see those results?
I cannot, actually.
Okay.
We
have 41% that are in urban, 46% in the rural, and 13% of our audience consider themselves in the frontier category.
Okay. All right.
Okay, this is Diana, and I'd like to thank everybody for joining us today. And I found your responses extremely exciting from a professional perspective. Terri and I both wanted to make sure that we were reaching out to those places that have lesser resources, and in looking at the poll results, it looks like over 60% of you, if you add both the rural and the frontier together, are in fact rural facilities. And my slides are not moving again, guys.
I'll forward it for you, Diana.
Okay. You want to go to the next one here?
No.
Okay. And I think the important piece for all of us who are on the phone today to think about is that pediatric trauma resuscitation probably in about 90% of the situations occurs at the closest facility. And that's not at all uncommon, especially for kids, and for rural and frontier areas. That's always going to be the place because EMS in most instances in rural areas is volunteer and also consists primarily of EMTs, and they are extremely uncomfortable with critically ill or injured children, and therefore they're going to go to the closest facility. So if we look at hospitals in general, approximately 5,700 hospitals exist in the United States, and over 20, the bulk of those hospitals are community hospitals, and approximately 20% of those hospitals are community hospitals that are subclassified as critical access hospitals. Some of you on the phone may in fact be providers from critical access hospitals. Critical access hospitals typically exist in rural or frontier areas as a first place for diagnosis, some limited diagnostic testing, some assessment, some early management. They have limitations on the number of days that they can keep patients, typically no more than 4 days. They are supposed to have transfer agreements and transfer guidelines in place so that patients who have greater needs than they can meet, they can therefore transfer those patients onward. And in most instances for the injured child, those processes are going to be extremely important to moving them onward to definitive care. As you can see here from the slide, less than 5% of our hospitals are recognized as pediatric or children's hospitals. The guesstimate is that there are approximately 250 children's hospitals in the entire country. And unfortunately, that does not mean that even though we have 50 states in this country, that every state has a children's hospital. In fact, you see some states that are truly blessed, such as Ohio, where 7 kids' hospitals exist, and then you find some that have an extreme void, such as Wyoming, Alaska. There are no kids' hospitals. They have pediatric areas in hospitals, general hospitals, but they do not have a pediatric hospital. And as you can see, there are even fewer pediatric trauma centers than there are children's hospitals. Not all kids' hospitals are peds trauma centers. This slide, as you can see, indicates where all of the level 1 pediatric trauma centers exist in the country, and as you can see, there are extreme areas of void up in the mid to northwest area, and you see that states that exist in those areas, large states, are without pediatric trauma care at all and frequently require very long distance across state borders for trauma care. Next slide, Terri. So the important thing to understand is that if we want to improve initial resuscitation for kids, we need to understand where kids are being treated. And as I mentioned earlier, 31 million kids each year are seen in emergency departments, and the bulk of those, over 90%, are treated at local community hospitals. And the rest of these kids, when they're treated, are frequently treated at hospitals where they see less than 20 or less than even 10 kids per day. So for those emergency departments, which many are rural and community EDs, they're not going to be as comfortable in seeing kids, and their resources are going to be extremely limited. Next slide. So in 1995-96, the American Medical Association came up with some guidelines of what they believed every emergency department should have as far as equipment, trained staff, medications, policies and procedures, quality improvement, and processes to ensure safe practices. In 2002, the American Academy of Pediatrics and the American College Emergency Room Physicians built upon those right resources and right requirements for emergency departments. And then again in 2009, AAP, ACEP, and the Emergency Nurse Association came into play and partnered and came out with the newest joint position statement and guidelines for care of kids in the emergency department. And it's these guidelines and that we are now working from on a national level to ensure that every emergency department is prepared for kids adequately to assure that trauma resuscitation and initial care of all kids can occur. I think we can all agree that if you're not prepared for everyday emergencies for kids, you certainly are not going to be prepared to do pediatric trauma resuscitation. Next one, Terri. Okay, so for kids, and for many of you, if you were around when I believe it was the old Blue Book for resources for optimal care of the injured patient came out, they talked about an inclusive system, that in order for trauma care to be effective, that every hospital needed to be prepared to take care of basic injury care. And for kids, it's important, regardless whether they're injured or whether they have a medical problem, that there also be this pediatric readiness. So we're saying that an inclusive system is needed for that. In 2010, the EMSC program partnered with AAP, ACEP, ENA, and many of the national organizations getting expert consensus together to work together to develop a pilot assessment. The pilot assessment was done in California with a 90% response rate to see how prepared are hospitals. And then in November of 2012, we took that pilot assessment, converted it to an electronic assessment, and we did a field test in Maryland, Minnesota, and Guam. And hospitals took this assessment, it was self-reported, to see how prepared were they for kids. In January of 2013, we rolled the assessment out nationally, and much to our surprise, over 4,000 hospitals in this country participated in that assessment. Never before has an assessment received such participation, we believe. And we were extremely excited that the hospitals participated. It says to us that, number one, hospitals want to do what's right for kids. Hospitals aren't quite sure what they should be doing to assure readiness for kids, and therefore that's why they participated in the assessment. Once the hospital's identity was kept very protected, because we did go through IRB approval, and we realized that there is some competition that goes on between hospitals, and therefore we wanted to make sure that the hospitals felt that their responses were being kept very confidential. Can we go to the next slide, please, Terri? So when the hospitals responded to the assessment, They got back an immediate gap analysis, which showed where they were deficit and what kinds of things they could do to improve their readiness for children. And we'll talk a little bit more about that in just a second. The median assessment scores for 2003 were 55%. Now, that does not mean that 55% of the hospitals were totally ready for kids. It means that 55% of the hospitals had approximately 85% of the equipment and policies and procedures in place to provide care for kids. And only 69% of the hospitals in 2013. We saw an increase, but there's still obviously opportunities for improving the readiness of emergency departments for the care of kids. Next slide, please. So, as I mentioned, if you were the person taking the assessment and you completed it all, you got back your gap analysis, you were then told where the voids were. And in order to help hospitals address those voids, the stakeholders who were involved in the initial development of the assessment tool and the study of America's EDs and the National Resource Center for the EMSC program worked to develop a pediatric readiness toolkit. And what you're seeing is the front page of this toolkit. The toolkit has a section on administration and coordination of emergency departments to assure that kids are addressed in there. It addresses educational needs of folks who work in the ED, quality improvement, policies and procedures, including transfer and the need to have transfer agreements and guidelines in place. And all of that can be located on the internet. At the end of this presentation, we have a list of resources, specifically websites, where you may go and find this information and look at it if you so desire. Next slide, please, Terri. So here's a question for you that will help us see how much of the trauma community really understands about Peds Ready.
Okay, so to participate in the poll, how would you describe your knowledge of the Peds Ready project? Just select with your mouse. We have about 50% voting, so I'll give you about 10 more seconds. I'm going to close the poll and share those results. Okay. It looks like we have 15% that are very familiar and have participated in the survey. 23% have a general awareness. 13% are aware of the project and their facilities results. And 49% of the audience first heard of it today.
Well, I'm really glad that you're on the call today so that you are hearing a little bit more about it. There's just so much more that's exciting to share. For those who were in the B, C, and the D category, I would advise or suggest that you all go down to the emergency department and see if your emergency department manager, educator, or quality improvement individual actually completed the assessment. For us to have gotten 4,000 responses back, I would assume that most of your EDs did participate. And if you want to have a beginning or a first step to think about for trying to improve pediatric trauma resuscitation in your EDs, you first need to know, do you have the right resources and tools available? Can we go on to the next slide, Terri? Okay, another point that I think folks need to understand is that not every hospital can be prepared for every type of pediatric emergency, and especially trauma. And if we look at some of the data here about the workforce, and I was involved in trauma care for about 15 years before I moved to the National Resource Center, I knew that pediatric surgeons were limited, and I certainly knew that pediatric-specific rehab physiatrists were limited in this country, but I really didn't have a clear picture of the limitation of resources to help optimize the outcomes of injured children till I started delving into the training programs and how many folks really exist that are board certified, how many are the programs actually able to put out. And I think when you look at these numbers, it's clear to say that kids really, they don't have much of a chance of accessing the bulk of resources unless they go to a tertiary care level 1 pediatric trauma center in most instances if they're severely injured. Even PICUs are very limited, and the bulk of PICUs sit in the bulk of kids' hospitals, which we already know are also limited. So resource limitations are always going to be a critical denominator in trying to assure that kids get the resources they need, and therefore pediatric transfer is going to have to be the norm. And that initial assessment and determining which kids need to be moved is going to be critical for every hospital. In 2005, the federal EMSC program began developing performance measures that every state was to work to achieve over the ensuing years. In 2007, we collected our first data on availability of interfacility transfer processes, looking at both agreements and guidelines. And guidelines, we have a very specific list of components that need to be included in those guidelines. And as you can see, the numbers were deplorable. There may be a trauma system in place in your states, but if there's no agreements and there's no guidelines to move children onward, chances are that trauma resuscitation is going to be limited and prolonged prior to that child getting to the resources he or she needs. We collected data again in 2010, and as folks became aware, we began to see guidelines and agreements being available in more and more facilities. In 2013, those numbers are continuing to go up, but as you can see, there are still lots of areas for improvement, and I would dare say that the trauma system in most states would improve dramatically if transfer processes were clearly in place in every hospital in this country. Next slide, Terry. So the things we cannot change: geography, transport time, and distance, and weather. We can't do much about that in the rural communities where many of you are working. But the thing we can do, let's move to the next slide, is assure that those transfer processes are in place. And fortunately for the EMSC program, and I would dare say it's probably because I have the pleasure of working with nurses in both ENA and STN, we were able to get together an ad hoc group of about 10 folks, and over the course of about 9 months, we worked to put together an interfacility transfer toolkit. This particular toolkit has become part of the Pediatric Readiness website resources. It also sits on the Emergency Medical Service for Children's website. Download and adapt them for their own needs and have these tools in place to move forward. The specific guideline considerations that the federal program with many additional stakeholders felt needed to be included in a transfer guideline, define processes for initiation of transfer, including responsibilities of referring and facilities and receiving facilities. There needs to be a dialogue between the two facilities, and the receiving hospital should have an expectation of helping the sending hospital know what it is they need to send with the patient, how they can help the patient more safely be transferred, and if need be, many of the receiving facilities have transport teams, sending those teams out to help the sending facilities. Selecting the most appropriate facility. Where I worked, we had 2 pediatric level 1 trauma centers. One had a burn capabilities. Mine did not. We took very small minor burns, but otherwise we were fine as a level 1 pediatric trauma center. So even though hospitals had transfer agreements with my facility, they very quickly were told, if you get burns, you probably would be to your advantage to also have an agreement with the other level 1 pediatric trauma center. So we need to think about those components as well. Process for selecting most appropriate transfer vehicle, that's pretty inherent for trauma. I think most of us have dealt with that. Plans for transferring patient record and patient belongings and signed transfer. And the last one of these points, plan for provision of directions and referral institution information to family. EMSC and most of the federal programs are looking at consumers, how are programs impacting consumer, and for parents, that impact is knowing where their child is going. Where do they go? Do they go to the admitting office? Do they go to the PICU, or do they go to the ED? It's a very stressful period for them. So as caregivers who are transferring patients, we have an obligation to provide them with as much information as we can. We do have a family advisory network at the resource center, and that resource that works with the resource center, and those at family advisory individuals are part of every EMSC advisory committee in each state. And many of those state programs now are working on putting together a packet of desired information that parents would like to have if their child's going to be transported. Next slide, please. Okay, so here's another question for you all. Does your facility have transfer guidelines in place to facilitate transfer of injured children to needed specialized pediatric care? Kim?
The poll is launched, so you have a choice of yes or no. We've got about 60% voted, so I'll give you about 10 more seconds. We had about 70% vote, and it looks like of that we have 89% that says yes, and only 11% said no.
Okay, thank you, Kim. I think that result is excellent, and really shows that just what Diana's been talking about, that again with the limited pediatric resources, that again children are transferred very often. So it's good to hear that a lot of that stuff is, that behind the scenes stuff is done and ready for those kids. So what I'm going to talk about next from the level 1 pediatric trauma center side of things again is looking at ways that we can overcome some of those challenges in the rural environment. So I want to just start out with talking about, does it really matter? So this is data from our own rural regional trauma advisory group here in southern Minnesota. And we were looking at, again, as part of the trauma system, things that we can look at to provide better outcomes to patients. So we started out by looking at patients who were transferred from our own regional area into our level 1 pediatric and adult trauma center. And again, you can see the numbers are about the same, but again, the things I have circled there, again, the average number of minutes from time of injury to definitive care, you can see in the patients who were transferred in is about 3 times higher than those patients who came directly from the scene. But interestingly, the injury severity score is much lower on those patients who came from other facilities, but again, the mortality rate is higher. So again, our thought process is there that if we can work on that time to definitive care would be a good project, something that again might help us to improve trauma care within our region. And again, we have the data to really put behind that and use that as a performance improvement project in our region. So what are some of the things that we did, again, to try to overcome? Because again, when you think about rural, that distance and that geography is certainly a part of that, but also if providers are not as accustomed to dealing with children, again, that a way for us to overcome that lack of experience and those resources as well. So again, our Regional Trauma Advisory Committee, we call it SMART-TAC. We've been around since 2008, so I'm sure many of you have been involved in rural trauma care, regional trauma care much longer than that. We're pretty infantile, but we think that we're really doing some good things. And one of the things we did very early on was to form a subcommittee just looking and thinking about projects that we can do related to children. And again, we did have the benefit, again, of having collaboration with the Level 1 Trauma Center in the region that has proved to be very helpful as well. So again, regional trauma system is just a way of having a bunch of different discrete components interacting really for the best interest of the patient. So that's always the defined goal, is to improve morbidity and mortality for our injured patients, children certainly involved in that. And again, we think that's especially important with specialty care. Again, Diana did a great job of showing how there's just a lack of pediatric resources available in certain areas of the country. And again, having a way to deal with that, overcome that challenge from the regional standpoint is extremely critical. So again, this shows the majority of our Southern Minnesota Regional Trauma Advisory catchment area. So again, the blue dots are the level 4, the critical access hospitals in our catchment area. So again, the majority of the hospitals that we're interacting with are level 4 critical access hospitals. There's one level 3 trauma center to the west there. So again, lots of time, lots of geography, lots of distance between definitive care and some of these level 4 hospitals. So one of the things we thought we better start with, again, is to provide all of those regional providers with an idea of really how they should handle a major pediatric trauma patient, you know, starting with the basics, if you will. So the first thing we did through SMART-TAC was to create a practice management guideline, really telling those providers things that if you work with kids all the time you take for granted, such as shock recognition in children, fluid resuscitation in children, but again, realizing that if you're not as familiar with taking care of children, that might not be as intuitive. So we got to start with the basics. So this was approved in 2013 and really formed a basis for us to kind of build off of in our regional trauma group. So participant question. So again, as you can tell, I'm very passionate about the importance of regional trauma systems. So just wondering what you would consider your participation in your regional trauma organization, whether you consider yourself active, maybe work on some projects, you're aware of it, slightly involved, plan to get involved, or maybe you don't have regional trauma groups in your state.
Okay, the poll's launched and we've gotten about 60% voted. So we'll give those of you still participating about 5 more seconds. Okay, we've gotten about 70%. Looks like there's still a couple more. I'll give you another second or two. Okay, close the poll and share the results. Okay, Terri, it looks like we have 63% that are active, 6% work on projects, 16% are aware and attend some meetings, 6% plan to participate, and 10% do not have any regional groups.
Okay, thank you, Kim. Well, I'm very pleased to see that the majority are involved and active, because I do think there's so much benefit to that. And again, for those of you that are planning to, I can only encourage you, because I think there's tremendous networking and, again, things that really do benefit the patient that takes place at those meetings. So more power to you on that. So again, this is one of the other projects that we worked on through our regional trauma organization. Again, we created and approved a set of regional trauma team activation criteria. What we found was that every hospital kind of was using their own criteria, especially when it came to children. They were kind of all over the board. And so we felt that this really was a way to create a very standard language across the entire region, certainly not only for hospital providers, but for EMS agencies, even for law enforcement when it came to potentially calling for auto launch of aeromedical support and things like that. But we also thought that these trauma team activation criteria would not only be helpful for the hospital, but they could also use them as triage criteria. For example, if a child came in that met the highest tier activation criteria, that would also be a patient that would anticipate that child would not stay at that level 4 trauma center very long, but would again help those providers to expedite that transfer to the definitive care that that child would need. And again, when we think of that data that I showed at the beginning, where the average time from injury to definitive care was 200 and some minutes, again, any way that we can use to chip away at those minutes to get patients where they need to be quicker, and we really felt this was a way that that could help us with that. So here's what those criteria look like, and I hope you can see them. We did have an adult and pediatric criteria. Again, it made it much easier to have them separate, so that people were not focusing and trying to look through the adult criteria for the child criteria as well. After we approved these criteria through the regional trauma organization, we spend a lot of time going out and educating people. We went to all providers, to all hospitals in the region. We went to EMS agencies because, again, we felt the value of using these standardized criteria, again, would truly help diminish that time to definitive care and, again, ultimately help us achieve our goal of decreasing morbidity and mortality associated with injury. So these came out about a year ago. And again, we're working to gather some good regional data so that we can evaluate their effectiveness. And so again, hopefully more to come on that. One of the other projects that we did, again, when you think about rural trauma, overcoming geography and lack of resources and experience, was within our trauma center in our hospital here. Our aeromedical services, again, we realized that some of those more critical access hospitals didn't have the ready access to blood products that trauma patients need. So they actually began carrying packed cells in 1987 and actually began carrying thawed plasma in 2009. So they carry 3 units of each on all 3 of the helicopters within our system. And so a couple years ago, we wondered, really how often has that been used with our pediatric trauma patients? So again, we did a retrospective review of that data, and again, we looked at 9 years, and again, not used very often in children, as you can imagine, as compared to adults, but we were able to identify 16 patients with a mean age of 13, and again, an injury severity score of 30, which is not surprising. Again, there's very stringent transfusion protocols that the helicopter has, so again, these are kind of the sickest of the sick patients, if you will. But what we also found was that the hemoglobin, from the time they did their first one on scene till they got here, was shown to have increased. Their base deficit improved, and we actually were shown to have 3 unexpected survivors based upon TRIS methodology. So again, we feel very good about that, and there's been multiple studies on the adult counterparts with this group, and again, has shown to be very, very beneficial to our region. Another question. So again, we've been talking a lot about geography and lack of resources and lack of experience. So just wondering from the group before I get on with the last part of my presentation here, what approaches you may have utilized to deal with some of these challenges that perplex us that work in the rural type environment. Education, outreach, PI, maybe enhanced equipment, or other.
On this poll, you can select more than one, so go ahead and select all that you have tried. It looks like voting is starting to slow down, so I'm going to give you about 10 more seconds to put in your answers. Okay, and we have 70% of our audience voting, and it looks like of that 87% of them have used education, 77% of them have used outreach, 55% using PI, 36% using enhanced equipment, and 13% said they had tried other.
Great. That's excellent. Well, I think it shows that we can identify these challenges, and there's lots of different ways to deal with that. So I'm just going to talk next a little bit about some of the things that we have used here at our Level 1 Trauma Center to overcome some of these challenges in the rural environment. So I hope most of you have heard about the Rural Trauma Team Development course. Again, this is an American College of Surgeons course, really designed specifically for being taught in rural, low-volume trauma centers. And, you know, ATLS is all about stabilization and taking care of all these these serious injuries. But the Rural Trauma Team Development course really differs from that in that it really teaches them to rapidly assess and certainly intervene as they need to, but it really talks about making sure that these patients are transferred promptly once they realize that this patient exceeds their capabilities. So again, one of the mantras that we really do focus on is that it's not necessary for these patients to have all of their imaging done prior to transfer. Again, when we look back at that graph about the 209 minutes in those outside facilities, again, when we go back and look at that, a lot of that is devoted to imaging. So again, if we can get that thought out there that we don't have to have all that imaging prior to transfer, again, it's another way that we really think we can cut down on that lack of time to definitive care. One of the nice things about the Rural Trauma Team Development course, well, there's many, but again, the course is taught at their own facility, at their low-volume critical access Level 4 trauma center, using their equipment and really using the teams that they have available to them. So again, they may use their EMS providers after they bring the patient in as part of their team. So we include all the different disciplines, and the content can really be tailored to the needs of the facility. So there's lots of interaction with the leadership at the facility prior to the course. You know, maybe they're having trouble with teamwork or imaging or whatever the case may be, and we can really tailor the content to that. And we have been able to show that the time to decision to transfer does improve. And again, the course is fairly easy to put on. It's some lectures and again, very low fidelity simulation. So again, we teach about 4 to 6 courses annually through our trauma center. And we decided in 2012, again, thinking about the kids, that we're always going to include a pediatric specialist as part of the faculty. So sometimes one of my pediatric trauma surgeons will go out. Sometimes I will go out as part of the faculty. But again, we always want to make sure there's someone there that can provide that pediatric insight into all of those great points that they're making throughout the course. And then we also did create a pediatric case scenario to use with the low fidelity simulation. So again, it really can emphasize those key management points that are important when you're taking care of children. Again, if these providers don't have as much experience with taking care of children, again, it really emphasizes those things to them in a non-threatening manner. And the other thing we try to do is really involve the regional trauma team activation criteria during the lectures, during the scenarios, to get them used to thinking about using that And again, that's great because there's so many disciplines involved in that course. The other thing that we did from the Pediatric Level 1 Trauma Center was we really decided we needed to go out and do some outreach with these low-volume trauma centers and really, provide them some face-to-face contact. So it's, they recognize us and we recognize them. So again, if we have to deal with them later on a PI project or a transfer issue, it makes that conversation go better. When we did these visits, again, we did 23 within about a 3-year period. Again, all of the visits started out with a review of a case that was transferred from that trauma center. And what we found was that it was a really great way to open up discussion and to kind of facilitate those discussions as we went. So that was very helpful. So we always tried to deliver the same global messages. We always talked about shock recognition because it's so different in children. And we talked a lot about imaging because, again, most of these providers in these rural hospitals are adult providers. And so our imaging concepts are so much different in children. Again, especially if you think about the PCARN document with the head imaging guidelines and so on. So we really focus on that a lot. We talk about time sensitivity, again, the importance of getting that patient where they need to go. And again, what are the differences between adult and pediatric trauma care? Because these are all very, very good adult providers, but again, just pointing out the differences sometimes is very helpful to them. For example, with circulation, again, we talk about vital signs and perfusion assessment. Again, the use of capillary refill in children that they might not be used to with adults. Again, the fact that persistent tachycardia in an injured child is shock until proven otherwise. We don't rely so much on hypotension. How everything is weight-based, and again, that you can use blood products in children safely, again, in a weight-based format. So those are just some of the things that we really focus on. So one more question. So again, what is the key message that's delivered in the Rural Trauma Team Development course? And again, that they should do all imaging prior to transfer, that they should stabilize and then make an early decision to transfer, and that the trauma team leader role is not at all important to a well-functioning trauma team.
We've got about 70% voting right now, so we'll give you about 5 more seconds to put in your response. Okay, and it looks like we have 100% of those say that stabilization and early decision can improve patient outcomes.
Perfect. That is great. Diana?
Yeah, there we go. Well, first of all, I'm really impressed that you all got that. Every one of you got it correct, got the correct answer there, and I know Terri is just beaming over there. Our hope is that this webinar provided you with an understanding of some of the reasons why every ED needs to be prepared to take care of critically ill or injured children. We also hope that we addressed effectively that transfer processes are extremely important to assure that injured kids do have access to the specialty care and the resources that they deserve, and that they're not going to be available unless those transfer processes are frequently in place. And regionalization, as Terri talked about, provides opportunities to all trauma centers to standardize specific components of pediatric trauma care and to work together to do performance improvement. She also wonderfully addressed multiple approaches that can be utilized to address the lack of pediatric-specific resources, whether they be experience, education, tools, quality improvement again, and hopefully that those who joined us on the phone today will find this of some benefit. And want to go to the next slide? I think we are done with the actual presentation in the PDF that Kim prepared for you all. We've listed some various websites and links where you may get information on that our presentation was based upon and that may be of help to you. And I think we've got a few minutes for maybe one or two questions if folks have them. Is that right, Kim?
Yes, we have 4 minutes. There's not any questions currently, but feel free if you have any questions to go ahead and type those in and we'll take those. As Diana said, this is a new feature for our platform, so I believe you should be able to see a PDF of the slides under the Handouts tab. If not, I'll make sure you get those with the email that you should be receiving in about an hour with the directions to complete the evaluation. So we'll wait just another minute or so to see if anyone has any questions before we end the broadcast.
For doing the polling with us, because neither Terri nor I have used this particular feature for webinars, and it was really actually kind of fun, and we learned a lot from you guys.
Okay, we have a couple of people that are saying thank you, well done. Okay, here comes one question. Someone is asking, how do they know if they have an RTAC in their area, or RTAC?
I would go to, if they have a state trauma system, I would go to the leaders of the state trauma system, and they would certainly know if there's an effort to regionalize in your area.
Okay, so more thank yous, and since there are no more questions, thank you again for participating. If you think of some questions afterwards, feel free to contact STN headquarters, and we'll try to get those answered for you. And we will hope everyone has a wonderful afternoon.